Hello everyone, welcome. In this short video presentation, I'll talk about the typical ECG changes in MI or myocardial infarction. So the typical ECG changes in myocardial infarction can be divided into two phases. One is acute phase and another one is evolving phase. So acute phase occurs just after minutes or hours after a complete blockage of a coronary artery, which leads to ischemia, and the acute phase is characterized by typically ST segment elevation, which is the most common type of ECG changes, but sometimes there can be also tall positive or hyperacute T waves. So those two are the most common features. But later on, there might be development of Q wave in case of transmural MI. So transmural MI is actually associated with Q wave development and also ST segment elevation. And in the evolving phase, which occurs about hours and days later, there is actually development of deep T wave inversions in those leads which have actually previously had ST segment elevations. And in some people there can be persistent ST elevation about 1 month later, and if there is systolic mitral regurgitation associated with that ST elevation, it should suggest that this patient has already developed ventricular aneurysm. So there are typical leads for denoting the area involved in myocardial infarction. So I have just made it simpler for easy memorizing, that for if there is any obstruction in the left anterior descending artery, it will lead to change in anterior leads, which are lead V1 to V4. So this should suggest that there is an infarction involving the anterior surface of the chest. So those are the anterior leads. And if there is an obstruction in the left circumflex artery, there will be changes in lead 1 and lead AVL. So this will be called a lateral MI. And if there is an infarction involving the right coronary artery, this should lead to the changes in the inferior leads. So for inferior leads, you can easily remember that except for one, you have two II, and three I's. So lead 2, 3, and inferior for the F, you have the AVF. So 2, 3 AVF are the inferior leads. And in case of right ventricular MI, you can put an extra lead which is called V4 on the right side. It is actually 100% specific. So the ST elevation is MI typically is more than 2 millimeters in chest leads and more than 1 millimeter in limb leads. So here you can see the evolution of extensive anterior MI changes. So here, why you call this extensive anterior? Because you can, as you can see here, there is changes, or there is ST elevation in lead 1 and also in lead VL. So you can see the ST elevation here, and also lead V2, V4, V6. So there is extensive changes in the anterolateral wall in the chest, in the heart. So that's why we call it extensive anterior MI. And this is an ST elevation MI, which after some time, now the leads that showed ST elevation now is showing T inversion. So T inversion here, also here, also here, here. So later on, those T inversion also becomes normal, like you can, as you can see in the C. So T inversions is becoming flatter, and flatter. So now you can see evolution of inferior wall MI. Why we are calling it as inferior MI? Because you can see some ST elevation in lead 2, 3, and AVF. So you can see the ST elevation here, and here. And those ST elevations are actually replaced by T inversions after some time, and ultimately those change will be normalized after days or weeks. Actually, the ST elevation in MI can have different type of shapes, so it can look like this, or directly spiky, or be flat, or just have a dome shape. But whatever the shape is, the most important point is the J point. So J point is the junction point where there is the junction between the S wave and the start of the ST segment. So this junction is very important to remember. So here, this is the J point, this is the J point, this is the J point. So very important to remember. So this is the part where the QRS complex actually junctions with the ST segment. Very important. And here you can see another extensive anterolateral MI, where you can see the changes from chest lead V1 up to chest lead V5. So we have ST elevation here, also V3, also V4, and some stimulation in V5. and later on those ST elevations are also increasing because the changes are going on inside the heart. So you can see typical changes of ST elevations in different leads. Here here is a comparison between subendocardial and transmural MI. So in case of subendocardial MI, the subendocardial vessels are occluded, and that's why the myocardium actually not full myocardium is not involved. Only the subendocardial myocardium is involved, and that's why it leads to formation of ST depression rather than ST elevation, because the current of injury actually travels inwards, and that's why this current actually goes against or away from the chest leads, leading to ST depression. But in case of transmural or epicardial MI, which occurs due to total blockage of an artery, the current of injury goes towards the injured side, and that's why it leads to ST elevation, and also later on it leads to development of key waves. Here you can see the typical features of subendocardial infarction, which is characterized by ST depression. So here you can see ST depression and also another ST depression. So that's all basics for typical changes in MI. Thanks all for watching my video.